Hello everyone, this is Dr. TSR. Today I am here to teach you regarding hysteroscope. Okay, hysteroscope, hystero means uterus, scope means to look. So you want to look the uterus. How? Through vaginal. It is a minimally invasive procedure. So this is about hysteroscope. Okay, so what are the parts of hysteroscope? It has a scope and the scope contains some inner sheath and it also contains a outer sheath. Then there is something called irrigating channel. Then there is something called light source. And if you are operating, then you will have another more channel, that is operating channel. So you have a scope, then you have a inner sheath, then you have something called as outer sheath, then there is irrigating channel where we will put the irrigating fluid, then we have the light source, and if you want to operate we have something called operating channel. Okay, this hysteroscope is of two types. One is diagnostic, another one is operative hysteroscope. Okay, so this scope whatever I told, so this contains this can be of two types, either 0 degree or 30-degree angle. What 0 or 30 means? See, this is the uterus, right? So this is the uterus. So now you want to put the hysteroscope inside. If it is 0 degree, 0 degree means there is no angulation. So this is 0 degree. So when this is 0 degree, what we can see is only the parts which is there in front. This is the field of view. But when it is 30 degree, what we can see again it is the uterus, but it is 30 degree. 30 degree means there is some angulation. So when it is 30 degree, we can see from one angle to the here. So we can see one cornwall end of the uterus. So what we usually prefer is 30-degree angle scope. Okay, this is with respect to 0 degree and 30-degree angle. So what are the other instruments we will use along with this hysteroscope is we can use grasper if you want to grasp the polyp, or we can use resectoscope if you want to do the resection of septum, uterine septum, or you want to remove the polyp, we have the Caesar. So these are the other instruments which we use along with this hysteroscope, right? So when it comes with hysteroscope, so the uterus will be there. This has there will be anterior and then posterior. Usually it will be opposed to each other. There is minimal gap. But now you want to see what is there inside this beautiful uterus. So we have to distend the uterus, right? So when we want to distend the uterus, what we will use is something called as distending media, right? So distending media can be of two types. Either it can be air or it can be liquid. Air means carbon dioxide, usually used earlier. Nowadays, usually we are not at all preferring air, and air only used in diagnostic procedures, not in operative procedures, because air can cause air embolism. So we are using liquid, and in liquid also there is something specific, like it is low viscous liquid. Means it is not a high viscous, not high. So it is low viscous fluid which we are using, and there are two types of fluid. One is isoosmolar, that is NSRRL, or another is glycine hypoosmolar, glycine or mannitol. Okay, this isoosmolar NSRRL is conductive medium, whereas glycine is non-conductive medium. Okay, so what is the use of this using non-conductive media? So when you use non-conductive media, whatever the energy you will give will be specified to that local pathology. It will not disperse. So we can use unipolar current here, monopolar current. Here we will use bipolar, not unipolar current. Okay, but what is the advantage of this NS and RL is we can use more fluid. And the fluid deficit allowed for NSRL is 2500 ml, whereas for this is only 1000 ml. So you want to do some procedure with this fluid, then 1000 ml is the fluid deficit. Stop the fluid procedure for that day. So that is something called two-step hysteroscopy. When you are removing fibroid, submucous fibroid, sometimes it is very difficult. Then stop the procedure for that day. Remove the half remaining part of fibroid the next day. That is about fluid deficit. So why for NSRL high fluid deficit is allowed is this is NSRL is not electrolyte, not having a very high molecular weight. You can easily cause it can you can easily remove the excessive fluid by diuresis. So we can use diuresis. So what are the points which will favor for increased fluid overload? When it comes with the fluid overload is, see, so the uterus is there, you are distending, so the minimum distending pressure required is 40 mm of Hg. Okay, but when you start increasing the intrauterine pressure, there is increased risk of fluid overload. Second thing, we have something called mean arterial pressure. If we are reducing the mean arterial pressure, if we reduce the blood pressure, then again there is increased fluid overload. Third is, if the fibroid is very big, like it has maximum myometrial invasion. If the myometrial invasion is more, then again it takes too much of time and there is more fluid absorption. Okay, increase in the depth of myometrial invasion. Then if you are taking more time for the surgery, longer surgery duration, or if the cavity of the uterine cavity is very big, uterine cavity is large, these are the conditions which predispose for fluid overload. So what to do when there is fluid overload? First is stop the IV fluid. First to stop the IV fluid, give her diuresis, and then look for any symptoms, whether she is developing nausea, muscle cramps, or electrolyte imbalance, finally going into cerebral coma. So this is the dreaded complication of hysteroscope, cerebral coma and pulmonary edema. So this is in brief about distending media which is used in hysteroscope. Now let us coming to the uses of hysteroscope, right? So when it comes with the uses of hysteroscope, it can be again two types. One is diagnostic, you want to diagnose something, or it can be therapeutic or operative. When you want to diagnose, what you want to do is diagnose if there is recurrent implantation failure or recurrent IVF failure. You want to see what is the infertility reason, unexplained infertility, or you suspect the girl is having some Mullerian anomaly, or there is an abnormal uterine bleeding, and you want to see whether there is an endometrial hyperplasia. These all are diagnostic. So what are the therapeutic? You want to remove the fibroid, submucous fibroid. I want to remove the polypectomy, fibroid, hysteroscopic myomectomy. So I want to do polypectomy. Or I want to resect the septum, hysteroscopic septal resection. Or I want to remove the adhesion which are formed within the uterus, that is adhesiolysis, that is used in Asherman syndrome. Or the copper T which is embedded within the myometrium, that is missing a UCD, I want to remove it. Or I want to take the endometrial biopsy. Or I want to do because of AUB, I want to treat her, that is transcervical complete resection of the endometrium. Or there is something called she coming with heavy bleeding and you diagnosed AV malformation, so you want to do laser coagulation of AV malformation. Or I want to do hysteroscopic tubal occlusion. What is that method called as? It is Essure. So if you want to do all this, then I will use hysteroscope. These are the therapeutic or operative uses of hysteroscope. And finally, if you want to do hysteroscope, so what is the ideal time? Ideal time is post-menstrual time. Post-menstrual endometrial thickness is very less, so we can easily go inside and see for the abnormality. So and do the procedure, that is post-menstrual period. So when it comes with the finally, the last touch-up point for hysteroscope is complications. As I already told, the first dead-end complication is fluid overload. I have even explained the management of fluid overload. Then it can be uterine perforation, or it can be false passage. Instead of going into the cervix, you have created your own passage, that is false passage of the uterus. Or there can be hemorrhage. So what to do when there is hemorrhage? See, usually I told 40 mm of HG is enough, but if there is hemorrhage, increase the intrauterine pressure to around mean arterial pressure, that is up to 70 to 90 mm of Hg, that will occlude the blood vessels. Or post procedure the patient may develop infection, or the procedure can undergo failure, or post procedure the patient may develop pyometra or hematometra. So these are something which is related to the hysteroscope and hysteroscope related complication. And finally, we will never forget whenever they ask for complication, that is anesthesia related complications. Okay, so when we use operative procedure, there can be thermal injuries also. These are some of the complications of hysteroscope. This is in brief about hysteroscope. Kindly do subscribe to my channel, like, share and comment for more.